Good afternoon, everyone. I want to thank you for attending this afternoon's webinar. Just as a reminder, all attendees are in listen-only mode for the duration of the webinar. However, our presenters are here to take your questions. We ask that you use the question box to type your questions in, and our presenters will address your questions later on in the session. Just as a reminder, the session is being recorded and it will go to the CSDE COVID-19 webpage. And I'm going to turn it over to Dr. Richard Melkrite. Rich?
Okay, thank you, Michelle. Good afternoon and welcome, everyone. The title and content of today's webinar is COVID-19 in Schools, Mitigation Strategies, Community Spread, and Decision-Making. This webinar is a collaboration of the State Department of Education, the State Department of Public Health, and the Yale School of Public Health. The presenters for today's webinar and discussants are, for the Connecticut Department of Public Health, Dr. Lynn Sosa, myself, Richard Melkrite, and Tom St. Louis. For the Yale School of Public Health, Dr. Albert Coe. Presentations will take approximately half of the time, and the remainder of the hour will be for presentations, for questions and answers. Next slide, please. Okay. Our role and approach is to be the public health advisors to educators like yourselves and others to help you translate the science into policy. In that spirit, we will quickly summarize key science and facts about the COVID pathogen relevant to school policy. The COVID pandemic is caused by the coronavirus, severe acute respiratory syndrome coronavirus 2. SARS-CoV-2 causes the pandemic disease called coronavirus 19. And 19 means it was identified first in 2019, so it is new and we are still learning much about it. We already have a clear idea, though, of how coronavirus is transmitted. It is transmitted easily, permitting a takeoff in the chains of transmission of viral infection if the chains of transmission are not quickly interrupted. It is found in highest concentration in respiratory secretions, saliva, and nasal mucus. Anything that gets saliva or nasal mucus from one person to another facilitates transmission: sneezing, coughing, close talking, singing, and the like, and even breathing in close quarters if sufficient time has passed. That is, within 6 feet for 15 minutes or more, or less time if someone coughs or sneezes right into the other person's face. Droplets of saliva or nasal mucus, and we're talking about droplets are about 100 microns in diameter or more, are the main mode of transmission of SARS-CoV-2. Droplets of this size do not dry out and do not stay suspended in the air for long. Instead, they fall to the ground within 6 feet. If they contact mucous membranes of the face, that's the mouth, nasal passages, or perhaps the eyes, they have a portal of entry into the body of the next person who can then be infected. However, droplets that fall on surfaces like desks or hands can be touched and moved from those surfaces to the mucous membranes of the human face. Risk due to aerosols of tiny particles, smaller than droplets, that can stay suspended in air is mainly associated with aerosols produced during certain medical procedures, such as nebulizer treatments. Symptoms are subjective reports of feelings, signs are objective findings. Symptoms and signs of SARS-CoV-2 infection are nonspecific and may be mimicked by many other viral or bacterial infections. Key symptoms are feeling feverish, shortness of breath, loss of taste or smell. You may also complain of bad headache or malaise. Key signs are documented fever of 100.4 or more Fahrenheit, new cough, rapid breathing. They may also have vomiting or diarrhea. According to CDC's review of the currently rapidly evolving medical literature, children can transmit to others, and while it is not exactly clear how easily they can transmit to others, there have been significant outbreaks associated with children, such as in a summer camp. Children can be asymptomatic, and that can range from, depending on where you look in the literature, from 16% to 45% of the children that have the infection will be asymptomatic. And asymptomatic persons can transmit SARS-CoV-2. Children are less likely to die or be hospitalized than adults, though it has happened. Of the quarter of a million cases, 294,000 cases, and 77 deaths in children to date, and that's 77.7% of the cases and less than 0.1% of the deaths. So deaths are relatively rare in children. Children with underlying disease, especially involving the heart and lungs and obesity, are at increased risk of serious disease. Children with cancer do not, at this point, seem to be at particularly increased risk of serious disease compared to other children. Could I have the next slide, please? Okay, regarding testing for COVID. COVID tests are tests for the causative coronavirus, SARS-CoV-2. Test samples can be obtained from respiratory secretions via a swab of the nose, especially the back of the nose or the mouth, the throat, by saliva, which is spit, or blood. The presence of virus can be determined by copying bits of its RNA genetic material to the point that it can be detected by a laboratory instrument. This polymerase chain reaction, or PCR test, is not an easy test to perform, but it is the gold standard and is sensitive, which means that it finds virus that is there. It does not undercall, and specific. It correctly identifies the virus and doesn't overcall. PCR takes at best 24 to 48 hours to turn around from sample collection to the report back. With shortages of testing supplies or high volume demand, this has lately been longer on a national level and may take up to several days for a turnaround. However, in Connecticut, laboratories based in Connecticut have maintained a good turnaround time. Saliva tests, and you may have heard about this new test prepared by Yale that's recently been in the news, use the PCR genetic test as just like the swabs. The Yale test is promising because it can cut down in the number of steps for preparation and maybe cut down the sample turnaround time perhaps and do it cheaper. We'll see how that works out. This is a new test and we'll see what happens. Antigen test samples are also taken by swab, but they don't measure genetic material of the virus, they measure viral proteins. These tests can be done faster, even within a few hours. However, while they're good at showing a test is positive, they're not as good at showing a test is negative and generally are not used in a situation like you might use in school. Antibody tests in blood measures the body's immune system reaction to viral infection. It shows past but not current infection and is of little use in school decision making. By the term screening, we mean using methods to determine who from a given population may have a condition of concern, such as coronavirus infection or other health problems. Screening can be done by getting a history of risk, reporting of certain symptoms, physical examination to find signs, such as temperature, or by laboratory or other types of medical tests or procedures. Using laboratory viral testing to screen for school attendance has its issues. Turnaround time, cost, the need to keep repeating the test because each test only shows what's going on with an individual at a certain point in time, and the occasional false positive test. Tests are better predictors and more surely used in decision making when associated with risk, signs and symptoms, history of contact with possibly infected other persons, more in the medical setting or with contact tracing. CDC recommends and provides instructions on symptom screening at home before coming to school. So that's a different type of screening. Something can be done just by determining how a person is feeling and maybe if they have a temperature at home. As for the screening for signs, the temperature screening will be, and the value of it in the school setting will be discussed later in this talk. Next slide, please. Okay, at this point, we're going to talk about decision making, and I will turn the talk over to Dr. Lynn Sosa.
Thanks, Rich. So we are going to go over how administrators will be looking at making decisions regarding full in-person learning, hybrid learning, or full virtual learning. So we can have the next slide, please. So I'm going to be talking a little bit about the indicators of community spread. And these are the indicators that we have chosen to focus on when we're looking at the metrics or indicators that schools should be using. And the primary indicator is looking for new community cases per 100,000 population. So those are cases that have occurred in the last week. So we'll be looking at cases that have occurred the previous Sunday to Saturday and calculating rates at the county level. And then for the secondary indicators, we'll also be looking at test positivity, again, looking at a daily average for the previous week at the county. And really it's cases and test positivity that I think people are very familiar with. This is the data that you're seeing every day. But we also wanted to look at severity of illness. So we've included hospitalizations, again, as a rate per 100,000 population at the county level. And then also to get more real-time data about what is going on with people that are going to the emergency room but not getting admitted and trying to understand what is going on there, we are able to look at COVID-like illness hospital emergency room visits. So can you click next slide, please? And then one more again. So the data that we shared on Thursday, which I'll be showing in a minute, is looking only at community cases. So we are excluding cases in settings like prisons or nursing homes because we really want the data to be focused on what is going on in the community. And we didn't want cases, for example, in a prison where there might be a lot of testing going on and potentially a lot more cases detected to influence that case rate. And we really want the data to be reflective of the school population as well as the teacher population. And I know that there's a lot of interest in being able to look at these indicators at the town level. And the reason that we chose the county level is that we want our data to be robust enough to be able to withstand changes that might occur on a day-to-day level and be able to understand that those data over a week. And so that is the reason that we don't do this on a town-by-town basis. The other reason is that our hospitalization and COVID-like illness emergency room data are not available at the town level. So we will be making the town level data available for both cases and test positivity. So people don't have to calculate on that their own, and they can look at that for context. But we really want to caution people for using those data when they're looking at overall decision making, because those data, especially and in small towns or places where there's small population, little changes can look significant and not actually be. So next slide, please. So if we're looking at our leading or primary indicator, which is new community cases per 100,000 population, we're looking at the daily average for the previous week at the county level. And I think people are familiar with our colors here. So if our case rate is less than 10 per 100,000, that is considered low and favors in-person learning. If the case rate is between 10 to 25 per 100,000, that is considered a moderate risk level and favors hybrid learning. And a case rate greater than 25 per 100,000 is high and favors remote learning. And so again, this is the metrics that we'll be applying to that primary or leading indicator. So next slide. So for our secondary indicators, so test positivity, new hospitalizations, and COVID-like illness, we're going to be looking at the trend and trying to determine if that trend is considered significant. So if the trend is stable or decreasing, that's going to be low, so it favors in-person learning. If it is stable or actually looks to be starting to increase, that would be moderate, favors that hybrid learning. And then if a trend is going just up or is increasing, then that is going to be considered high and favors remote learning. And we will be providing data to be able to look at previous weeks to be able to look at these types of trends. So next slide. So where can you find this information? So this past week on Thursday, we did share a document that had the latest information. Going forward, and I'm hopeful that this will be starting this week, these indicators will be posted online each Thursday afternoon and be available on a website dedicated to this exact purpose. And that is where the data will be updated every Thursday. So with the data being available on Thursdays, we would ask that school superintendents, districts consider having a standing meeting on Fridays to discuss your local situation. And as soon as that website link is available, we will share it. So next slide. So I wanted to be able to just show the indicators that we have shared as of August 13th. So this is the data we shared on Thursday. This actually reflects data from the previous Sunday to Saturday. And the reason that we are looking at that data is that by Thursday, we are pretty confident that those data are complete. And we want to be able to have complete data to be calculating these indicators. And you can see that for all of the indicators, everything is considered yellow and favors in-person learning. So next slide, please. So obviously, I think it intuitively makes sense that worsening data for those community rates, especially increasing case rates, is going to affect decision making. But that is, we don't want these metrics or these indicators to be the only thing that people are looking at, or to be looking at those colors and decide, oh, I'm in orange, I have to change what I'm doing. It's really important that these data are considered in context with other factors. And I'm going to pass it off to Tom St. Louis, who will be talking about those other factors. Thank you.
Thank you, Lynn. Next slide, please. So for those of you who've been on the other webinars we've had so far, this slide is not new to you. We've talked in the past about mitigation strategies as kind of a suite of approaches for schools, and kind of several different strategies that people can use in their schools to mitigate some of the effects of spread, specifically in those schools. Next slide, please. So it really is a systems approach to health and safety, as we think about going back to in-person school. And people have a lot of questions, and understandably, regarding face coverings. Are certain types and styles or fabrics better? In terms of that specific question, we think that potentially, the thicker the fabric, the better. We know a study just came out about neck gaiters. Again, just kind of cautioning people that that was one study with one item. The study was set up to actually test something else, and this was kind of byproduct data. So there's this tendency early in research to consider any new information as better information. We're not there yet. Certainly if you can, same thing with exhalation valves. Certainly if you can pick a cloth mask that's multi-layer, which is what CDC recommends, without an exhalation valve, although we don't know if there's a significant increase in infection rates related to exhalation valves. If kids are going to be sitting in the school for 6 or 7 hours next to each other, maybe picking a mask with without an exhalation valve is a better idea. Mask exemptions, we will be talking a little bit more about that coming soon. I don't know exactly when, but I know a lot of schools are already getting doctor's notes from people about exemptions to mask wearing. Generally, our message on exemptions is face coverings is going to be the whole ball game for schools. If you can't get every kid to wear face coverings, then you're going to have a difficult time dealing with some of the changes in data that you're going to see, possibly on a week-to-week basis. There aren't many true medical exemptions for not wearing a loose-fitting mask. If people have those, they're going to have a tough time getting to school, and we would recommend they not be in school anyway, because it's usually indicative of a severe respiratory condition, end-stage heart failure, something like that. So more to come on those things. We should have some guidance coming out soon on face coverings. Physical distancing, we talk about 6 feet all the time. That's kind of a standard public health message. For certain things, 12 feet should be observed. We're coming out with some guidance about wind instruments and chorus that talks about further distances. 3 feet, we've heard for most classrooms, 3 feet is about all they're going to get. In that case, it makes the other strategies even more important, especially face coverings. Hand washing, there's a lot of questions around that. Soap and water is better than hand sanitizer, although hand sanitizer is certainly effective. There's been some FDA information that came out about methanol present in certain hand sanitizers. So we would refer people to the FDA website. They keep a current list of all the hand sanitizers they've asked to be recalled because they've had some methanol in there, and methanol can be poisonous, either absorbed through the skin or certainly ingested. So those are the basic public health messages that we've been kind of talking about over and over. These should be new to nobody at this point. Some of the other things specific for schools are cohorting. We've had a lot of questions about what's the right size cohort. The smaller the better is really our answer. I don't think there's a right size, but certainly, you know, to the extent you can keep those cohorts smaller, the better. There are different cohorts kids are going to be exposed to. Yes, the classroom is a cohort, but there's also a cohort of people that travel on a bus together. There's a cohort of kids who play soccer together or do some other extracurricular activity, drama club or something together. So those are all cohorts, and the smaller the cohorts and the fewer the number of cohorts, the less infection you're going to see. Cleaning and disinfection and ventilation, 2 other important approaches and mitigation strategies. We did separate webinars on each of those, so those are posted, I believe at this point on the SDE website, and I encourage people to go watch those if they haven't seen them. And then identification, isolation, and exclusion of symptomatic kids, symptomatic teachers, anyone with a positive test result. And then we're going to have another webinar on Thursday to talk about contacts and contact tracing. So I certainly invite everyone to attend that and learn how kind of we're going to try to deal with contacts inside the school. Next slide, please. So Rich had mentioned previously temperature screening at schools. So for quite some time now, we've not been recommending temperature screening at schools. I know it was in the initial summer school guidance, but actually, I think before summer school officially started, we actually indicated that we didn't think it was a very good use of resources. We have found now as our information about COVID-19 has been increasing, that really elevated temperature is kind of a poor indicator for somebody's infection status. I'm sure many of you have heard stories about how 40 to 50% of people are completely asymptomatic. So the number of people you're going to find with 100.4 temperature reporting to school is probably going to be very small. There are risks involved with it. It creates bottlenecks at entry points. So you can imagine all these little kids waiting to get into school. You know, you've seen people lining up to get into their workplace and they know how to stay 6 feet apart. But anyone who's involved with schools knows that if you put 100 kids in line waiting to go through a temperature screening, it's quickly going to become a 100-kid crowd rather than a 100-kid line. We know that in a lot of these cases, there are inaccurate readings from the scan thermometers, and so you need to repeat test people. It's labor intensive, as I said, and it also gives people a false sense of security that if I made it through the temperature screening, then I'm not infectious, and everybody else in here is not infectious as well. So instead of temperature screening at school, we really recommend that schools give some ownership to students, you know, high school students, or parents about health monitoring for their children, to try to every morning talk about health. Do you have your mask? How are you feeling? Maybe even take a temperature every morning if the kid's feeling a little off. Next slide. So a couple things to do in terms of mitigation strategies before schools open, and hopefully you've all been doing this already, is really reaching out to municipal officials and your local health department to plan on what's going to happen with school reopening, how to operationalize some of these mitigation strategies, and some other things that are going to be involved when schools reopen. And of course, communicate what strategies are going to be in place at the school, how you're going to use those strategies, and what are the expectations for parents, what are the expectations for students, and also teachers and other staff in the schools. And then after school reopens, really using a few days in the beginning to train everyone on the new procedures, practice those new procedures, identify where there are problems, and retrain everybody on how to wear masks, where to wear masks, what are the policies for staying home when you're sick, and things like that. Be ready to adapt to changing conditions. One thing we know about COVID-19 is that we don't know what's going to happen a week from now. So be ready to adapt to changing conditions, especially if those conditions are increasing problems with compliance with any of these mitigation strategies. And of course, even after schools open, communication is going to be key. You can't over communicate any of these things. Daily reminders about masks, about social distancing, about who should stay home, and kind of anything you can think of in terms of policies and procedures for the school. Really important to communicate those frequently. Next slide. So CDC has a ton of print resources for schools that are looking for signage. There are signs for in the bathroom, there are signs for in the classroom. CDC has some great general public health posters, but there are also school-specific ones. So you can see they kind of have them for different age groups as well. So I would invite everyone to go on to the CDC print resources page and look at their posters. And other states have a lot of posters as well. And I've yet to talk to somebody in another state that says you can't use our poster for public health messaging. So this is the kind of stuff, this passive messaging that's kind of constantly hitting people in the face is going to be important as schools reopen. Next slide. And so, it is easy to get bogged down in the data metrics. It was one of our concerns with kind of putting out a bunch of metrics and using colors, was that people were going to say, we are yellow, we're all good to go. We are orange, we need to make changes, and just kind of be a little too simplistic about it. The reality is that this set of mitigation strategies can really help with the lift when you're facing some worsening data metrics. How well you implement these strategies, how big each one of these balloons is, and how many balloons you have to help you with that lift is going to determine whether you can weather a little storm of an outbreak or community metric that seems to be getting worse, or whether, if there's any change toward worsening metrics, the situation is so unstable in your particular schools that it's going to be best to shut it down. So, it's important, if you're going to have these standing Friday meetings, as Dr. Sosa suggested, that you want to talk about the metrics, but you also want to have a conversation about how all the mitigation strategies are going in all the schools, how closely people are following them, how often there are breaks in that chain of strategies, how often kids are showing up sick for school so parents aren't getting that message, problems with ventilation systems, or not having enough staff to do all the cleaning and disinfection you need. So those are all things, all these mitigation strategies plus the data metrics are the things you ought to be discussing on an ongoing basis with whatever your team is for dealing with school reopening in your district, whether that's elected officials. Certainly the local health department should be involved. Certainly the school medical advisor should be involved. These are discussions you should have and decisions you should be making on an ongoing basis. Next slide. And that's it. Again, thank you all for all you're doing to try to get our kids back in school. I know my sophomore age son is excited to try to go back. So hopefully we can not only get kids back, but keep them back for a long time this fall. So thank you.
Great, thank you, Tom. This is Chris Soto from the State Department of Education. So I'll be going to the question box. We do have a few to get us started. The first one is from Charles, who asked, is there a value in being even more cautious during the first 14 days of school, considering that this is the time frame during which families will have returned from vacations?
Thanks for that question. So I think that actually brings up 2 points. It is really important to recognize that any cases that are detected in the first couple of weeks of school very much will reflect what is going on in the community. And it is, I think, really important to remind people of that. And it is unlikely we'll be able to detect school transmission in those first couple of weeks. So understanding what other people are doing in the community, and then this also, I think, means parents need to understand what their kids are doing in the community, because obviously that's going to influence what might be happening at school. I think you're also referring potentially to people who are traveling and potentially traveling to states that are affected by the travel advisory. And so I think it is really important to make sure that parents are aware. Hopefully first, everyone is aware of the travel advisory. It's been in place for almost 2 months at this point. And new states are added or occasionally removed every Tuesday. And so when families are planning their vacation, they really do need to pay attention to that. And in general, we would not say that if somebody, travels into an affected state in those 14 days, they should not be allowed back to school, except in some very unusual circumstances. So I know that we've gotten some questions. People, there's a lot of misunderstanding about people being able to test out of the travel advisory. Those situations apply in very rare circumstances. We're working to clarify that on our FAQ page related to the travel advisory, but I would absolutely encourage you to make sure that your families understand the potential consequences of traveling to an affected state right before school, and that might mean that their student is not returning to school on time.
Thank you, Dr. Sosa, and I also want to welcome Dr. Albert Coe from Yale's School of Public Health, who's joined us as well to answer some questions. Dr. Coe, did you want to say anything before we jump to more questions on anything that was said in the webinar or just in general before we go into it more?
No, I think it was just very well covered by yourself and Lynn and Tom, so not much to add.
Okay, great. The next question that we had was specifically around a date when the updated mask guidance will be released. And I would imagine, so they're asking for a specific date, maybe if we had a rough estimate, but just considering schools are making decisions before families get back.
Yeah, I mean, generally CDC put out mask guidance recently about K-12 and cloth mask wearing. The general guidelines are going to be generally what they are already. I think there will be there may be some kind of suggestion that exhalation valves might not be the best choice for a school setting. I think that, a single layer of stretchy fabric might not be the best for a school setting, but in things like neck gaiters, right, we know that they're long tubes, so you can double and triple those. They certainly may be as effective as anything else in that situation. So I would caution not to read too much again into new information as better information, and really just work with your families. Tell parents to work with their kids to find a comfortable mask that they can wear all day long. In general, any face covering is going to be better than no face covering.
And just to add on to that, I think because specifically when you were presenting your piece, you talked about exemptions. And so I'm wondering if that's what this is in reference to.
Yeah, so I mean, basically, if you get a note for a kid from a doctor saying that this child is too medically compromised, so take out kind of the mental health aspect. That's a different thing. But from the strictly medical standpoint, and I don't know why I'm saying this. Lynn could be saying this better than me, probably, or Dr. Coe. But from a strictly medical standpoint, the contraindications for wearing a loose-fitting cloth mask are really things like very severe respiratory conditions, heart failure, things that would preclude somebody from really being ambulatory, walking around without assistance. So if you got a note from a doctor that said this child, for medical reasons, can't wear a loose-fitting cloth mask, I would question whether it's smart to have that kid in school at all, because their risk, if they do get infected with COVID, is very significant for severe complications. Lynn or Dr. Coe, I don't know if you have anything to add to that.
No, I think that's spot on. Really not much to add. Yeah.
Great. I will accept my medical degree from Yale soon. Thank you.
Okay. You already got the honorary degree.
The next question came from Kathy, and this is specifically around masks as it relates to OEC. And I think we've already kind of clarified this, but maybe we should just reiterate. Her question says that OEC has indicated children attending preschool are not required to wear a mask. However, Executive Order 7/NNN indicates that everyone over age 2 is required to wear a mask unless they have a documented exception. So I think this has been clarified that early childhood would not have that requirement, but kindergarten would.
We have guidance on that, Chris, on our website, and so maybe you can just refer folks there because we do have the OEC guidance there as well. That may be helpful. And just back to the other question you mentioned, we recognize that there's been lots of questions that have been sent to us about masks, and so we're working on getting those responses along with the guidance that Tom talked about as quickly as possible. I know the person wanted to know precisely when, but we're committed to doing that as quickly as we can.
Great, thanks, Charlene. The next question was from Jeff. Jeff, we'll get you a URL for this webinar, and then after that, we had a question from Kristen. So my school has been talking about mask breaks during the day. Can you provide suggestions about mask breaks? Some are worried that they will take place in the classroom. And I guess maybe just to add on to that question, is there any recommendation in terms of locations for the mask breaks, which is, I think, is her last point, and your thoughts on whether those mask breaks need to be taken in the classroom, what can be done for that strategy?
Yeah, I mean, ideally not in the classroom. If it can be part of a floating kind of break period where kids can either go outside if the weather is nice, or in a larger space like spread out in the auditorium or in the gym space or some other large space where they can kind of get that distance that's needed to drop that mask for a little while. It's really going to be dependent on the kind of space you have available. I know there are schools that are already putting up tents outside to do, things like band and classes if they want to do them temporarily, maybe also a good place for mask breaks. So I would say, be creative, try to get to a place where kids can give, 6 or more feet of space between themselves when they are taking those masks off.
Great. The next two questions are regarding playgrounds. And so both Tom and Jennifer, the first is essentially any guidance in regards to mitigation strategies for the use of playgrounds, and any thoughts on cleaning of equipment.
Yeah, I mean, we've generally said, and if you go back to the cleaning and disinfection webinar, we actually talk about outdoor structures. You know, the outdoor elements are very good at killing this virus, which is why we say outdoors is better than indoors for a lot of things. So we've, you know, we've not recommended that people need to clean outdoor playscapes and things like that, or wipe them down frequently. The outdoor elements will generally take care of outdoor spaces. You know, to the extent you can keep kids out of each other's faces when they're outside, that's better. But, you know, we understand that kids are going to be outside playing. Kids are outside playing now. So, you know, again, outdoors is better than indoors. And you don't really need to focus too much effort on cleaning and disinfecting the outdoor play structures.
Would that also apply in, you know, if you had a class that had a recess at 10 o'clock and then the next one is coming at 10:30 or 11, is it generally safe for the next cohort to be playing outside without a cleaning in between and wipe down in between?
Yeah, I mean, I don't know if Dr. Coe or Lynn or somebody wants to talk about kind of the risk that we're seeing from surfaces versus direct transmission.
Lynn, do you want to go first, or?
Feel free.
All right, okay. So, yeah, so I think Tom is spot on that. Okay, so they're really, the focus needs to be on person-to-person contact. We know from outbreak investigations, we know from transmission in households in many different settings that the highest risk is between people facing each other, and this is through the respiratory droplets. There have been outbreaks due to presumed outbreaks, you know, due to what we call transmission by fomites. For example, if I cough or spit on a surface and then somebody touches that and then touches their nose or the secretion, you know, their mouth or their eyes, there have been sparse, you know, documented transmission. There really haven't been actually, there's been one presumed outbreak. But by far and large, and I think the number that's, and we have to be kind of humble what we know and what we don't know. We're going to be learning, we're still learning a lot every day, but you know, it's almost like a 90-10% that 90% of the transmission is likely going to be person to person versus 10%. And those are just rough numbers that we're using to guide. So I think, you know, Tom, as you mentioned before, outside, we know that UV, you know, light or sunlight deactivates, you know, the virus. You know, warm temperatures also destroy the virus. So that kind of, in the beginning of the epidemic, we were really quite worried because we didn't really know a lot about transmission. So we're asking, you know, to really do aggressive disinfection. But I think now from what we're at, and I think Lynn, and throw it back to Tom, but I think it's really the person to person that we're worried about. That said, you are still going to want to disinfect frequently places that are touched, you know, because kids, we know they're touching their mouths and their nose, and even where they have the face masks are going to help a little bit with that, but they're going to be touching different places. So places like bathrooms, like doorknobs and those type of things, there should be routine disinfection protocols for those. Lynn, 90-10 rule, what would you say?
Yeah, and I'm actually hoping it's more like 95 or 98. So yeah, I mean, the emphasis is really on the person-to-person transmission and still keeping those common surfaces as clean as possible. And so we want to focus on the highest touch areas. I totally get people might be concerned about a playground. So I think what is more important here is while the kids are outside, trying to make sure that they are socially distanced. That's going to be more important outside instead of focusing on whether the jungle gym has been disinfected, but still having a plan for the routine cleaning of that playground equipment will be good.
And this is Rich Milk, right? I would also suggest if somebody sneezes, You know, make sure they clean their hands if they sneezed onto their hands. If they've sneezed onto their desk, clean the desk. So focus it on where you know those droplets have occurred. Make sure you get those. Those are the most likely cases we're going to get a so-called fomite transmission. And then these general cleanings are good, but I think you can maybe focus a little bit on that.
And just generally hand washing, before the kids go outside, after the kids come back in. Okay, everyone washes their hands or uses hand sanitizer. General public health practice.
And one of the nice things about masks are we very frequently touch our face more than we even realize. And one of the things about having masks are they remind you not to touch your mucous membranes of your face. So that's another little benefit there from masks.
Great. So I think, so Jennifer also, I'm sorry, Lois had a question about specials. Lois, I think that also answers your question about specials and cohorts being in classrooms. The next question is from Charles. If we have a positive case in a classroom that is cohorted, should we isolate the class, the school, or the district?
So that is exactly, that is the subject of Thursday's webinar, where we'll be sharing that information. And the short answer is that the contact tracing around that case is going to then result in the recommendation from the local health department about who are the closest contacts and who should be excluded from the school setting.
Great. And since you brought up local health districts, I'll just jump to this question from Linda. And so it says here that health districts and departments are being asked if they will provide similar guidance or documents that were developed by other health districts and shared in other school districts. Does the DPH have any plans to develop standardized checklists, screening algorithms, or forms for use by all schools? And I think this just kind of speaks to other stuff that we've seen in the past about continuity between health districts. So especially that could potentially impact choice schools because they're serving different districts. So any thoughts on this one?
Yeah, I mean, we've tried to put out kind of standard guidance for most things at this point. We still have a few to kind of, button up. Again, with any of these things, we really try to balance kind of putting it out quickly versus, like with the mask guidance. We could have put that out, the draft was finalized 2 hours before CDC put theirs out. And there's actually some changes that have been made to it based on CDC's guidance. So, we're always trying to collect the most recent information we have and put out that guidance. I don't know that we'll have standardized checklists and all those kind of things. I would think those would be part of every school's individual plan. They know kind of what operates best in their various school situations. But if people want, any of those things, I know CDC's got some of those things. Certainly, local health departments meet, a couple times a week and discuss and share items like that. So certainly, and I would encourage you, if you think your school district has a good one, or your local health department has a good one, share it around with your colleagues or to SDE to share around with different school districts. I'm sure people are always happy to take in any of that information and consider it for their use as well.
Great. This next question is from Ron, and it says, would you recommend schools limiting their programming in terms of sports or extracurricular activities in the first week so things can get a handle on? And I would say probably generally yes, but I'll let the experts weigh in on that.
Yeah, I mean, it's no surprise, and there was a lot of press around the fact that we did, suggest that sports be delayed at least, for a couple weeks to, more than anything, get people used to the idea of what it means to be wearing masks in schools, what it means to kind of try to get away from people basically in school, and really give schools the opportunity to work on some of those in-school strategies before you kind of bring in the added complication of either extracurricular sports or whatever it is. So, you know, clubs and things like that, certainly if you can delay those for a couple of weeks, I think that helps, or work on kind of how to do them virtually. That's great. And for athletics, you know, we're in constant communication with SDE and with CIAC about fall sports and kind of what that means, and hopefully we'll have definitive answers on that soon. But you know, we have kind of offered guidance in the form of the letter we sent to CIAC. So from our standpoint, that would be the recommendation.
Great. So this question I think is a good one because it speaks to you know, other concerns. So it's from Karen, and it says, if a student is sent to the school nurse because they are coughing, are there any guidelines regarding what disposition the nurse should have? I think this is just a good also segue to previous discussions around, you know, not every child is going to essentially exhibit, you know, like just because someone's coughing, not everyone has COVID, right? Like it might be flu season and they have the flu but not COVID. So I think this question speaks to that broader conversation, if we could touch on that.
Sure. So I would refer folks to Addendum 5, which addresses 3 scenarios. So the student that has symptoms but has not had known exposure to COVID-19, or also staff, the student or staff person that has symptoms and has been exposed, and then the student or staff person that does not have symptoms but has been exposed, and gives, we hope, clear guidance on how to assess those situations. And we've called out pretty the symptoms that we would be most concerned about. So things like fever, cough, feeling feverish, shortness of breath, difficulty breathing, loss of taste and smell. Like if a child or a teacher has any one of those symptoms, they should certainly be sent home and referred to their healthcare provider about the need for testing. And then we do give guidance about kind of what happens if that person tests negative, tests positive, or does not get tested. And so we have provided that information, and we hope that that's helpful.
It's also on our website, Addendum 5. It's there as well. So for the person asking, and others can just go there and get that information as well.
Right. This question is from Kevin and speaks specifically to eating lunch in the classroom. If mask breaks are recommended in spaces other than classrooms, what is your advice for eating lunches? And please also consider adverse weather conditions based on some of the past recommendations about eating outside.
Yeah, I mean, I would say generally, I know there are some, you know, there are plans to, you know, for some schools to increase the number of lunch waves, to shorten the time of lunch waves. You know, if kids are eating in classrooms, you know, the act of pulling down their mask to actively eat or drink for, you know, several minutes, up to, let's say, you know, 5 or 6 minutes when they're actively eating, you know, is probably not a huge amount of increased risk. But certainly to the extent you can get them away from each other, you should. I mean, I think people really need to be creative in their thinking about how these things are going to work, because you know, there is a tendency to say, well, everyone's in the classroom, let's just have them eat in the classroom. But there may be an opportunity to say, all right, half the class actually needs to go to the cafeteria to get their lunch, so that half will go down, eat spaced out in the cafeteria, the other half will eat here in the classroom, and that kind of stuff. So, you know, I think, you know, probably in the grand scheme of things, it's not a huge increased risk, but anytime you do that, it is increased risk. So some increased risk.
Great.
Add as well that tomorrow there's a webinar. So we're doing all these webinars, one in child nutrition programs. And I don't know if John is still on, but I know they're talking about some of those things, including, you know, attention to students who may have food allergies, and just making sure that folks are diligent in those areas. So I know that there's further conversation that will be occurring tomorrow. And I just saw John's, I don't see a camera on John, but I don't know if you wanted to add anything to that.
Tomorrow afternoon at 2:30, we sent out a link last week on Friday. If you have questions, you can send in questions to your county consultant, but we'll be talking about the frequently asked questions document that we sent out and some additional guidance that we're preparing to send out specific to the federal flexibilities and waivers around the school meals programs and your questions around how to structure the day and how to structure your meal program so that students have opportunities to eat. Thank you.
Thanks, John. So there are a bunch of questions about cleaning and surfaces. So I'm just going to direct everyone to the previous webinar that we did, so we don't rehash that. But it's very detailed, and so you can find that on our website. And also this last question from Helen, which talks about re-entry protocol for individuals that tested positive. Lynn, correct me if I'm wrong, but that was also in Addendum 5 about re-entry into schools. So
Yes.
again, I would encourage everyone to just look at the addendums and also the past webinars specifically to ventilation and also cleaning. This next question is just a clarification on something that you talked about, Lynn, with quarantining. So can you clarify that the guidance for students and staff is that they should not be able to provide a negative test in lieu of quarantining?
It depends on the situation. So if the person does not have a known risk factor, meaning they haven't been knowingly exposed or been in close contact to somebody with COVID-19 and they test negative, then they can return when their symptoms have resolved for 24 hours. If somebody doesn't get tested and they have an alternate diagnosis that can be documented, so for example, a child doesn't get tested for COVID-19 but is tested for strep and that's positive, and that's provided by the healthcare provider, that could be a way that someone is allowed back to school, again, when their symptoms have resolved. But if somebody has a known risk factor, so they've been exposed, they're considered a close contact to somebody with COVID-19 and they have a negative test, they have to complete the 14-day quarantine period.
Great.
And this is all distinct from the travel advisory.
That's right. Thanks, Rich.
Thank you, Rich. We have just a few more questions, and I think so if everyone is okay staying on like 1 or 2 more minutes, we'll just blast through these questions. We only have a small handful left. And so the next question is going back to outdoor time. And so, some people were looking at that time as potentially being the mask break. Is the guidance that students should still be wearing their masks while they're outside playing?
I mean, if you can get them to do that, that would be great. But, understanding that once kids get outside, they're going to want a break from their masks. I would say if you're going to have kids outside, playing in a sandbox together or something, then probably if kids are going to be in close contact for an extended period of time, then having them wear masks is a good idea. But if you're kind of have kids outside generally, kicking a ball around or something like that, it's probably less important to have them wearing masks. Certainly if they're being physically active outside, not necessary for them to have masks on, but they should have them with them so they can go outside safely, so they can come in safely. And so if they, have to be somewhere where they're sitting next to other kids for a certain amount of time, that they can put that mask on.
Great.
Right.
Okay.
The key is distance from each other, right, Tom? They need to stay apart from each other if they're not going to have their masks on.
Yeah, I mean, if they're going to be together for a long period of time and not having masks on, then they need to be apart from each other.
Great. And so this next question is about students and staff members that either have cracked hands from excessive washing and or eczema. Are there any recommendations to prevent or treat this before winter comes, because they can't expect to share lotion in the classrooms?
I'll leave that to the physicians.
Yeah, use lotion. Oh, sorry, go ahead, Dr. Ko.
No, it's good. Please go. I didn't hear the question so well, but It kind of broke up. Please go ahead, Rich.
Yeah. There was a question about people getting cracked hands from frequently using alcohol-based hand sanitizer. It's one of the advantages of using soap and water over hand sanitizer, but hand sanitizer is good because it does destroy the coronavirus. I think the key is to get ahead of the cracked hands, by also, and I think it's a good point, make sure that people do put on hand lotion and try to avoid getting kind of skin skin problems due to that. And I think it just will mean that once people do have, if they do have hand lotion in the school, that should not be shared, just like you shouldn't be sharing other things.
Great. And then this last question is about provider memos. So local physicians are asking if DPH will issue a provider memo regarding clinical guidelines to meet mask exemption criteria. Is a provider memo like that on the way?
Not at this time.
No. So I will say that this issue of mask exemptions has been discussed in multiple venues. So it's been discussed on a school nurses webinar. It's been discussed on school medical advisor calls. And I think a lot of pediatricians are talking about this and basically reiterating what you've heard on this call, that in general, there's actually relatively few medical exemptions to mask wearing. And if persons are really that fragile, then they are likely should not be in the school setting in the first place.
Great.
I would add to that, Dr. Sosa, that we had a virtual house call last week for families to talk to some medical providers. Again, there was a lot of questions around masks, and they were pretty much reiterating exactly what you said. One of their doctors on was a pulmonologist and talking about that issue as well. So I think everybody's kind of on the same page in answering that particular question. We also have some school medical advisors who have talked about if they get a letter in from a pediatrician, we'll probably do some follow-up conversations just to get more details for the reasons that you're talking about as well.
I think it speaks to, if you see a particular provider giving lots of exemptions, that's something that should be questioned, basically.
Great. Well, thank you to our panelists again. I know there are some questions in the chat box around cleaning. I would refer everyone to our past webinars and also the addendums. I think that will also speak to some of the questions around like the decision tree. And then additionally, there are other webinars this week. I think Dr. Sosa said it's on Thursday that's going to speak to contact tracing. Is that correct? So please stay tuned. Same bat place, same bat channel. Thank you again to everyone that joined us, and have a great day.
Thank you.
Thank you.